Okay, I'm going to go in my order. First, let's start with this placental abruption. So it makes it a little easier. Okay, placental abruption, folks. Okay, now what does that mean? First, some normal anatomy. Let's see. You have uterus. What are the three layers of uterus? The inner layer is endometrium, myometrium, and perimetrium. Is that clear, folks? So the endometrium, myometrium is full of muscle. That's why it's called myo. Okay, that gives the structural support. Endometrium is so important. You know, your endometrium is here. And endometrium has multiple layers, decidua basalis and all these things, okay? Now, when the fertilization happens, the placenta is literally attached to endometrium. Is everybody clear, folks? They are literally attached.
Could you label the layers?
Endometrium, myometrium, perimetrium. Okay? Endo, myo, peri. Endo inside, middle, myo, perimetrium outside, folks, okay? Now, imagine this is your placenta. From placenta, there's an umbilical cord that goes to the baby. Is everybody clear, folks? Okay. Now, who supplies? Placenta, there's blood vessel from mother that gives oxygen. Is everybody clear, folks? That's the idea, folks, okay? That's normal. Now, what happens is, any activity that increase blood pressure in the mother, hypertension. We already learned enough about hypertension. We know in the hypertension, the pressure is so high. That's why we call hypertension. Is everybody clear, folks? So imagine if the pressure is so high this way, what's going to happen? It's hitting the placenta to go away from the endometrium. Does that make sense, folks? So it can literally dislodge the placenta away from the endometrium. When the placenta dislodge, we call that placental abruption. So we call abruptio placenta. Is everybody clear, folks? So placental abruption is the English word where the placenta is coming separate. Now look at the book, the last picture, placental abruption. It becomes separated and they started to bleed inside because they are separated and they are bleeding, okay? Now, it's called abruptio placenta. That's a medical terminology. Premature separation of placenta from uterus prior to fetal delivery. Usually, this should separate when the baby comes out. Is everybody clear, folks? But here, it has come out, which is bad, okay? Risk factor, look at this, maternal hypertension. Okay, maternal hypertension. Anything that gives you preeclampsia is that, smoking. You know, in Chicago, when I did OB-GYN rotations, we've seen a lot of people with cocaine. So when they use cocaine while they're pregnant, what happened to the blood pressure? Cocaine increases blood pressure, okay? So that's that. And any abdominal trauma, any of those things, folks? I want you guys to highlight, this is a painful vaginal bleeding in the third trimester, because out of this entire page, I think that's the only one that has pain. So the pain symptom is very easy to differentiate. So now what's going to happen? The mom's blood is leaking in there. Is everybody clear, folks? So can I tell mom is becoming hypovolemic? Okay. Can lead to maternal hypovolemic shock and DIC. Okay. Fetal distress. The baby is not getting oxygen because the blood is disrupted here. It's a life-threatening to both mother and fetus. What's the treatment? Go back, super glue and stick it back? No, we don't. So what do? The baby has to come out. Okay, we have to do it. There's no choice. And most of the time they are premature. You know, those are the babies get to stay in the hospital like a month or two. You know, sometimes these babies stays in the hospital for a month or two before they can discharge, right? So that's placental abruption. Is everybody clear, folks? All right, that's first disease.
That's right. In your drawing, the B was for the baby.
Baby, yeah.
The black dot, that's the placenta.
This is placenta. This is the umbilical cord. Okay, that's an umbilical.
Detached from the endometrium.
Say it again.
Is it like detached from endometrium?
Which one, the placenta?
Yeah.
Yeah, placenta attaches to the endometrium.
So when you say abrupta, it comes off the endometrium.
It
right?
comes off of the endometrium, yeah. Okay, so that comes off of there. So that's the umbilical cord, okay. Umbilical cord has umbilical vein and umbilical artery. And remember, umbilical vein is the one that carries the oxygenated blood here, folks. Okay, so that's that. Is everybody clear here, folks? Okay, let's go to the next one. Now this should make sense. Let's go to placenta accreta spectrum. Okay, let's go back here. I'm just going to erase a little bit here so we could understand this, okay? So we just mentioned when the placenta attaches to the uterus, it should only attach to endometrium. Is everybody clear, folks? It should only attach to endometrium. Sometimes it goes more deeper. This placenta can attach more deep. It can go deeper like this. It can go all the way, guys. It can go attach all the way. So there's a 3 different name: placenta accreta, placenta increta, placenta percareta. Okay, so 3 different name for the 3 different level of attachment. You could see that picture. That's normal, beautiful. It should stop here at the endometrium. Now, when we call accreta, it's coming a little bit more. Increta, it's even more. Look at percareta. That's like all the way outside the uterus. Is that clear, folks? So now if you see, it's formally called morbidly adherent placenta, or it's simply abnormal invasion of trophoblastic tissue into uterine wall, risk factor, prayer, C-section, some other uterine surgery, any of those. Uterine scarring of impaired normal decidualization. That's where they attach in the endometrium. Placenta, previa, all these things can happen, folks. But what you want to pay attention to those 3 things. Placenta accreta mean it's mild, attached to myometrium without invading it. That's the most common type. Increta mean it invades into the myometrium, and the worst one is percareta that goes through myometrium and sometimes even the neighbor tissue like bladder. It can go all the way, folks. Okay, so that's this. Presents with difficulty separating placenta from uterus after fetal delivery. Severe postpartum hemorrhage if they try to remove it. So normally, let's talk about this. In a healthy time, what happens once the baby comes out, when they pull the placenta, when I say they pull, it's literally like a mild pressure, like 5 millimeters of mercury, a tiny pull, the placenta comes off nicely. Here, no matter what, it won't come out. So can you pull it? Oh, so what do you do? So what do you do for this patient? The baby's out, baby's safe. So what do you do? So the treatment for this patient, she's done for the day, which means hysterectomy. The whole uterus comes out. No more babies. Okay. So when people have this, it's hysterectomy. So the treatment for placenta accreta spectrum, because remember, guys, you cannot cut it. It has to take it off, right? So that's hysterectomy is the treatment for this. Just for curiosity, I read it on the news, not now, it's about 4 or 5 years ago now. In Ohio, I think it happened. One of the surgeon, OB-GYN, and the patient had this condition and he worked for 48-hour shift, which means he was tired, judgment is impaired, whatever it is. He pulled the placenta a little harder when she had this condition. It ripped through her uterus and everything, and she died on the table by excessive bleeding. I don't know anything more than that, but I know this has happened, and it's an error of a doctor because, you know, he should have known that patient has this medical condition before even the labor because it's identified way early. Does that make sense, folks? So what's the problem here? Most of the doctors don't even read patient notes before they go inside, right? They come to you and they ask you what happened in the last time, right? No, they should be reading everything on the computer nicely before they come in. This condition would have been identified on the 2nd trimester when we do ultrasound. Does that make sense, folks? So they don't. That's the thing, you see. No, they don't. And it's like, you know, you go for a little antibiotic, they always ask you, what antibiotic did I give you last time? I tell them you could look it up on the computer. It's there. Look it up. Why do you have to ask me? It's all in there. You prescribed it. See, what they do is they don't want to waste that 5 minutes. They rather see one more patient and bill more, right? But no, look it up. Right? Or you could mess up the doctor. For most of the time, if I go to any of my doctor, I don't tell I'm a doctor. They ask me what antibiotic I gave you. I tell them it's like a blue pill. I don't remember, doctor. So they have to go look it up. Because you don't want to confront them either, right? Because when you change the color, it freaks them out, right? Because antibiotics are not blue usually, okay? I just said blue because most of the Viagra pills are blue. I just wanted to mess them up with that. That's why I say that, okay? But you just tell them and then they will look it up. All right, so that's placenta accreta spectrum, folks, okay? That's that. Is everybody clear here? Next condition.
So, when do they basically use placental ablation, like
Say it again?
laser treatment? Placental ablation, like laser treatment that they do.
No, maybe when you become OB-GYN, you could invent that surgery. Now, remember, placenta has to come out. If the placenta stays inside, it will cause DIC and it will kill the mother. Okay, we can't do any ablation or anything. When you see a delivery, when you do rotation, as soon as the placenta comes out, what the doctors do, we have a white color cloth. In that white color cloth, we open the placenta. Why? We do a color contrast because we want to make sure every single piece of placenta is out. We don't even want to lose a tiny piece. That tiny piece will cause DIC in a few days and sepsis. Okay, it has to come out, folks. Okay, right. So that's.
You mentioned blood vessel. In one. This is what blood vessel would this be that would be involved in the hypertension?
Which part are you talking about?
In the original diagram.
Is this one or you're talking about placental abruption?
Abruption.
Oh, any blood vessel that's supplied to the placenta it's a uterine vessels. Any uterine vessels. Okay. All right. So that's that. Now next, placenta previa. Let's talk about this. Okay. Now, folks, let's say I'm drawing another uterus. This is the uterus, and this is the mother. Okay. Okay, that uterus is way bigger, but just understand that. Okay, so that's a mom. The old style, when we do C-section, last generation, 20 years back, we used to cut right in the middle here. Okay. So that's mom's belly. Okay, that's mom's abdomen. We cut vertical incision. We take the baby out, no problem. But then that leaves a big scar in the middle of the belly. The moms don't like it. Cosmetic effect. They don't like that lesion right there, right? So then what they did for cosmetic purpose, we started doing a new incision like this. It's right there. It's a horizontal incision way down. That incision is called actually bikini incision. That's the name of that incision. So it can cover so they cannot be visible. Is everybody clear, folks? So when they are cutting, so we are cutting the lower part of the uterus. Is everybody clear, folks? That's fine. We cut it. We take the baby out. Everything is fine. When she becomes pregnant second time, you have placenta standing there. Placenta is supposed to be attached here. They try to go and attach here because when you cut and you heal, it becomes a scar tissue, isn't it, folks? Scar tissue has more blood supply than a regular tissue. So because of a scar here, the placenta prefer to go attach there because they have more blood supply. Does that make sense, folks? So nothing wrong now. So you attach it, the baby grows, everything is fine. The question is, can they do normal delivery? They cannot do normal delivery because if the baby comes down, it will break the placenta. We cannot do normal delivery. Look at this picture, folks. This is placenta previa, what I talked about. The placenta is right there. How can the baby come down? If the baby comes down, it will rupture, baby will die, and the mom will die. Is everybody clear, folks? So what do we have to do? C-section. It has to be a C-section. Now, when you go to rotations, you will learn placenta previa has two types, full and partial. Okay, what is full and partial? Sometimes they obstruct halfway through, but as the gestation enlarges bigger and bigger, it will actually move away. Is that clear, folks? If you have a partial and it moves away, and during ultrasound, we could identify if it moved or not. If they move, then you could attempt normal delivery. Is that clear, folks? But then if it is full, there is no way you could do it. So everybody clear, folks? That's placenta previa, partial and full. Okay, so that's too much for you guys. Step one, it's full and you cannot do normal delivery, folks. Okay, that's the idea. Now let's take a look here. Attachment of placenta over the internal cervical os. You could see placenta is visible through the cervix. You could see that. The risk factor, prior C-section. You see that, folks? The prior C-section. Presence with painless vaginal bleeding in the third trimester. Highlight that word. Painless, no pain. Whereas you abrupt your placenta, painful bleeding on the third trimester, same time period. Is that clear, folks? How do you differentiate that? One is painful, the other one is painless. Okay. If they say, you see, it's a low-lying placenta located 2 centimeters from, but not covering the internal, that's called partial, basically, okay? So if it is partial, they move, folks. You know, keep in mind, this is the size of the uterus. My fist is the size of your uterus. That become big to hold a baby. So as they enlarge, the placenta can sometimes move and make the cervical os clear. So everybody clear, folks? But again, you do a ultrasound. That's why if you see the last couple of weeks of labor, like before the delivery, they do ultrasound almost every week, isn't it, folks? You have to go do ultrasound every week because we want to see how things are happening, folks, okay? So that's placenta previa. Are we clear? All right. Now the last one, vasa previa. Now, before I even teach, you could look at the picture. That should explain what is vasa previa. Vasa means blood vessel. You see, this blood vessel should be running like that directly to the baby. Instead of running like that, it's going around the baby like this. Is that clear, folks? Now you tell me, can this baby come down? If it comes down, what will happen? It will break this blood vessel, right? If they rupture that blood vessel, the baby will bleed this way, mom will bleed this way. Okay, that's called vasa previa. Fetal vessels runs over the internal cervical os. Fetal vessels travel of placenta unprotected, nothing clinically important, folks. Presence with painless vaginal bleeding upon rupture of membranes accompanied by fetal heart rate abnormalities. Now remember, in kids, not kids, in fetus, increased fetal heart rate is normal. Is everybody clear, folks? The minute fetal heart rate drops, it says bradycardia. That's a worrisome, folks, here, okay? That's a worrisome. May lead to, highlight the word, fetal exsanguination. What is fetal exsanguination? The kids, the fetus bleed to death, okay? So because what happened, imagine, folks, the fetus is like a small, tiny size, and you have like barely 300 to 400 ml of blood in the body, that's it. It takes like a minute or two to bleed that. Is that clear, folks? So even if they rupture, usually they say, let's say a patient coming in, it's already ruptured. Can you get into the uterus in 2 minutes? No, it takes at least 10 to 15 minutes to do it because you have to get the patient sedated and then we have to cut it and go. Does that make sense, folks? So it's very hard, okay? It's very dangerous. So usually what happens, folks, when they have vasa previa, again, you know it from the week 30, 35 by doing ultrasound. So the physician, OB-GYN, what they do, we call external cephalization, which means they try to move the baby. You know, they massage the mom's belly. They can rotate the baby sometimes. That will take the thing away sometimes. Those things, you will learn it on step 2 CK. See, when you go to step 2 CK, what you're going to learn, you're going to learn the treatment for vasa previa, which you already know now what is vasa previa. So when you learn the treatment, that makes it easier. Is everybody clear, folks? So that's
Is there any umbilical cord strangulation in this?
Sometimes it can happen. So, you know, that's a good question. Sometimes what happened, while this is happening, if the baby moves a lot, they go around and the umbilical cord can strangle the neck. If they do that, what's happening? No blood flow to the fetus head. Does that make sense, folks? Brain and stuff, right? So those are the complications of it. So those are the complications where the blood vessel, this is a straight picture. Sometimes they go around the cord and stuff. If they do that, there is no way you could do normal delivery. You have to do C-section, folks. You have to do C-section right away. If not, if they strangle the neck, no blood flow to the brain. Okay, it is very dangerous. They do C-section right away. Okay, so that's vasa previa. Is everybody clear, folks? All right. So that's placental disorders, folks. Okay, now we are continuing with that. Next one, uterine rupture. This is another complication, the whole uterus rupture. Okay. Full thickness disruption of the uterine wall. Again, risk factor prior C-section, because C-section always create a scar tissue and you lose the elasticity, so you cannot stretch. Is everybody clear, folks? All right. Now, usually occurs during labor in a subsequent pregnancy. Okay. Abdominal trauma and stuff. Presents with painful vaginal bleeding, fetal heart rate abnormalities, easily palpable fetal parts. That's important. Okay, easily palpable fetal parts. Why? Because the fetus is outside the uterus now. Okay, so you could see it. It's life-threatening for mom and fetus. Life-threatening. Usually this kind of condition, right, that vasa previa, uterine rupture, sometimes they will tell you they could only save one person. They ask you to make a decision. Right? I would pick my baby, not wife. No, I'm kidding. It's wife. Okay. That's what it is. All right. So to talk about that vasa previa, I had a vasa previa when I was in my mom's belly. So I had a thing that goes around the neck and I had a whole fetal hypoxia to brain. So it was an emergency C-section. And the doctor asked they could only save because my fetal heart rate was dropping and everything. So when they asked my dad, and of course my dad said, mother, I was like, jerk. No, So it's the idea is, and after I was born and they told him 3 days I would die because the oxygenation was so low. And even if he survived, he will become a retarded. That's what I was told, right? And I hope I'm not retarded, but I survived. Sometime I told this story to my wife, and sometime, she asked me to do things in the house. I don't do it properly. She's like, I think that fetal hypoxia is affecting you. I was like, really? Right. So anyway, it's commonly happens, folks, right? So that's the idea. Now, that's uterine rupture. Is everybody clear?
Doctor, so can you explain that one more time? So it's basically the uterus can't stretch, and
it's basically it's not really stretch. So there's multiple factors. One is a scar tissue, the whole uterus ruptures inside mom's belly, basically. It's like one small crack is what you need. It's a small crack, that's it. The fetus hand will come out. Okay, so that's the idea, folks, okay? That's all right. Now, next, postpartum hemorrhage. Postpartum hemorrhage is after bleeding. So let's talk about that a little bit also. Now, once the baby comes out, there's always some bleeding is there, folks, okay? There's always some bleeding is there. That's why if you notice it, once the placenta is out, like you see, as soon as the baby is out, the OB-GYN doctor never spend time with the baby. The baby is taken separately by the midwife and they do everything, Apgar score and all these things. If you notice it after placenta comes, the OB-GYN goes and compress the mom's belly. They push it and they kind of compress to get all the blood out from the uterus, okay? Because there's always some bleeding. And they also massage the uterus because remember, this is the size of your uterus. Now it's like a big balloon. It has to go down, okay? So always the bleeding is there, but sometimes the bleeding can be excessive, folks. That means they are bleeding more than what they expect, they started bleeding. That's called postpartum hemorrhage. It's greater than expected blood loss after delivery. So some students memorize and say, oh, there was a bleeding after that. Every mom will bleed no matter what, but this is becoming more than that. How do you notice it? If the bleeding is there, that's normal. We would see blood pressure dropping. If blood pressure is dropping, that's a sign that she's bleeding more than what she expects. Is that clear, folks? Then what do we do? Oh, of course, IV line is always there and things are there, but that's a sign. Now we will see more here. Leading cause of maternal mortality worldwide. That's the biggest problem worldwide because, imagine if the mom gives birth at home and if she has this bleeding. There's no way she would even know it or control it, folks, okay? So that's that. Etiology. This is a must. What are the reasons? Uterine atony. So after the baby is out, the uterus is stretched. It's not doing anything. We call soft, baggy uterus. That's the most common. That's the most common, folks. Number 2, trauma. Some trauma can happen, or some tissue is retained, or some blood clotting issue. All these things can happen, folks, okay? So the treatment you need to know for the atony. So what do you do at this point? You have to make the uterus to contract somehow. So the treatment, if I were to write here, your object, right? Object to have uterus contraction. Object to have uterus contraction. That means the first step, what we're going to do, uterine massage. You need to know, number 1, that's the order. There's an order of doing things. So whenever the uterus is big, we massage. That's what the OB-GYN do. So when you massage from outside, you are kind of stimulating the muscle to contract. Once you start contracting, the bleeding will stop. You know why? The blood vessel in the uterus is perpendicular to the fibers. So think this way. This is my muscle fiber. This is the blood vessel. Once the uterus contracts, it will collapse the blood vessel so you don't bleed after that. Okay. So uterine massage, that's the first thing that we do. If that doesn't help, what if I massage for 15, 20 minutes? The blood is still keep coming out. That means your massage is not helping. The second step to give the artificial or synthetic form of oxytocin, it's called Pitocin. Pitocin is the famous brand in the United States, folks, okay? So we will give Pitocin. We don't like to give Pitocin because it hurts so badly when you give it. Because why? Pitocin is causing uterine contraction. So, but we have no choice. If you are bleeding continuously, you give Pitocin. Okay. If that doesn't help either, then we have to go for surgical ligation, folks. We have to either ligate the uterine artery or internal iliac arteries, folks. They ask this in the exam, which artery you ligate. You must know it. If they ask you, that's much better than they put a picture and ask you to identify. Okay, and I hope they don't do that. I haven't heard it, but one day it will happen. I don't know when. So that's the artery, uterine artery and internal iliac artery, both of them. So one of the questions you could ask me, if you ligate, what happened to the uterus in the future? No, fertility is still preserved because there's a lot of collateral circulation, so she would still get blood flow afterwards, folks, okay? So that's postpartum hemorrhage. Is everybody clear, folks? All right.
The objective is to make the uterus contract more.
That is the key, yeah. But if the oxytocin and the massage doesn't work, there's nothing we can do. So we have to cut the blood flow.
The contraction will slow the blood?
Yeah, contraction will slow down the blood bleeding in there because of the blood vessels. Okay, that's the idea here. Now, next disease is ectopic pregnancy. Okay, ectopic pregnancy. Ectopic pregnancy is defined as when the fertilization happens outside the uterus. Is that clear, folks? Simple. They're going to a different house than where they're supposed to. So that's ectopic pregnancy. Now you could see the normal structure. This is ovary, fallopian tube, and how the fertilization happens, folks. Okay. Now, the most common site of fertilization ectopic is somewhere in the fallopian tube. Okay. That's the idea. Implantation of fertilized ovum at the site other than the uterus, most often in the or fallopian tube. Okay. Risk factor, tubal pathologies. What does that mean? A previous scarring or PID. PID stands for pelvic inflammatory disease. That's the #1 risk factor for ectopic pregnancy. Or previous ectopic pregnancy, of course, we have that, we go for that. So that's ectopic pregnancy, folks. Presence with first trimester bleeding or low abdominal pain and stuff. Often clinically mistaken for appendicitis, but that's a differential. How do you suspect? Suspect in patients with a history of amenorrhea, lower than expected rise in beta HCG, right? There's a chart. For this many weeks, you have to have this much of beta HCG. If they don't match, there is something not right. Is everybody clear, folks? So for 25 weeks of gestation, it has to be this much of beta HCG in the blood. If not, there is something not right. And then we always confirm with the ultrasound, right? Why? Sometimes they are wrong on the date. If the date is wrong, you will pick the wrong amount of beta HCG, isn't it, folks? So that's why we do that. Which may show, extraordinary abdominal and stuff. So we have to remove surgically and then do methotrexate as a treatment. So that's the treatment for ectopic pregnancy. Is everybody clear, folks? All right. So that's that. Go take a break and come back. I'll have a question ready.